Urinary problems in female, they're usually of two types: storage and the emptying disorder. Storage, we know it's overactive bladder or SUI, or both OAB and SUI. Voiding problems. Usually, when the female comes, the urinary storage problem, she herself say very clearly it's urgency, increase in frequency, nocturia, or any activity which raises the intra-abdominal pressure leads to the leakage of urine. But when it comes to description of the voiding problem, majority of them when female just says पेशाब करते समय दिक्कत होती है, पेशाब खुल के नहीं आता. Now, we as a urogynecologist or in our daily OBGYN practice, we need to evaluate this a little bit more. So, usually when we refer to the female voiding patterns, we usually refer to the book Female Bladder Outlet Obstruction by Dr. Nikhil Khattar from Delhi, Dr. Rishi Nair from AIMS New Delhi, Dr. Arvind Pandey from Hyderabad. So today we are going to learn from the expert. Yes, we are very grateful and blessed to have with us today Dr. Nikhil Khattar. To expert himself, the author himself will teach us what are the female voiding patterns and how to evaluate the symptomatology of it. So please welcome Dr. Nikhil Khattar. Thank you, sir, for coming us and teaching us the female voiding patterns.
Thank you. Thank you so much.
Also, thank you for giving
Dr.
that
Mohini,
time.
For first of all being dedicatedly working in this field, because this field really requires people who dedicate their time to understand this. This is still an evolving field, and I think there is a lot that needs to still come out, and there is a lot more understanding that still needs for people like us who dwell into these problems, for us to be able to uncover all this.
So today we have come with the most difficult topic, I think, as a PG and SRs and all the, I think we'll correlate today with the topic. So first of all, so today I would like first to request you, please explain us what are the female different voiding patterns, how a female voids.
So, uh, voiding patterns, if we look at them uh, theoretically, it is well understood that women do not require the bladders in the female bladder, the detrusor, female bladder muscles, does not require that much of pressure. They don't require exertion of that much pressure to expel the urine as in men, just because of the fact that the prostate is not there, the long urethra is not there, so that turbulence it does not have to overcome. So generally women pass urine with a much lesser pressure in the bladder and still with a very good flow, so they do not require that. And because of that, although the voiding patterns are a little bit different as compared to men, they have their the study of these voiding patterns is also sort of, it has lagged behind. There was more focus always on men, just because of the prostate. It was thought that uh, because the prostate causes problems, so entire focus of these voiding problems was sort of they took that entire focus, and it is now only that this focus has shifted towards women's problems. So now, mostly from the research uh, in incontinence, mainly, now that we have come to know so many urodynamics that happened uh, in women who underwent these urodynamics because of problem of continence, and they did not have any voiding problems, but their voiding patterns then were
By UDS.
yes were then they were then revealed. And then we came to know that many of these women do not actually require any pressure to pass urine. Many women just void by relaxation of
From the
pelvic
pelvic
floor. They do not require even a slightest amount of pressure. The bladder contraction does not even happen. They just relax their pelvic floor and the urine comes out with a gush. And a few of them, it has been seen that few of them require uh, like mm, abdominal muscle,
Okay, abdominal
straining. So that is called Valsalva voiding. And then there is a third pattern where some of them do require detrusor pressure, and so that is, so all this comes under the category of normal. But how this impacts
physiology of
how
female, it's
yeah,
still under
for all
evaluation.
practical purposes, all of them are normal as long as
Okay.
the urine flow is normal. They do not have
Okay.
any urinary complaint, and the flow on flowmetry is
Metric
also
is
normal.
normal.
Then that is not a problem.
So
All
if
is
the patient
physiological.
is flow is patient have no complaint, and if the uroflowmetry flow denotes normal, then we can consider everything is to be normal.
Yes.
Okay, so basically, just to summarize, it's by detrusor contraction and pelvic floor relaxation, or only pelvic floor relaxation, or even by addition of the abdominal straining, right, sir?
Yeah.
So let's discuss symptoms. Most important, as we described, symptoms. How is the patient? So first symptoms are hesitancy.
Hesitancy, I would say, I explain my patients hesitancy. What hesitancy means: when urine actually hesitates to come out,
Yes.
when it takes time, that it is hesitating to come out. Somebody is ready in the position on the toilet seat, and urine is
It's
taking
not
time.
time.
है ना?
So I'll just describe the patient comes, the urgency, the sensation of full bladder. They goes to urination with a sense of urgency. Usually have urine problem. They go to the bathroom with a sensation of urgency to pass urine as soon as possible. But when they are on the seat, they take some time. So
Yeah,
that's
even urgency, I would not say that urgency is related to it. Urgency is a different phenomenon. It may not even be urgent. It is just with a full bladder. You want you go to the toilet seat
I want
with.
to say like both the patient. One is like patient goes normally when there's a sensation and goes to urine,
Yeah.
but then the urine does not come
Urine
and
does
take
not
time.
come,
That is
and it takes time.
hesitancy. And the patient even complains that she's having the repeated urgency to go. She wants to go to urine, but when she sits, it
Yeah.
is
There are many patients, in fact, who say that I have to sit on the toilet seat for many minutes, even hours.
prolonged
They say
boarding
that
time.
I do not
Okay.
know they are exaggerating or not, but that is what they say. They are so troubled that they say that it takes me hours, and then they have to do some maneuvers like rub here or
Rub
touch there,
there.
or sometimes they open the water jet,
Jet.
and they put
Wet
the
the
water on their genitalia, and then only the urine starts
comes.
coming.
So what
So
is
that can be the extent of that hesitancy. So
why this lead? Means why? What you think suggests when the patient comes? Like if some patient is having only hesitance, where the patient complains, then what might be the functional problem, obstructive problem, or
see, just one symptom
is
alone
not there?
is
Obviously.
not.
So
I will, like, there are so many other symptoms, and
sometimes
I
we'll
will ask
combine them.
each one of
Each,
them,
so
and
we
then
proceed
only.
for the next symptom, which is most commonly slow stream or the poor stream.
Yes, then slow stream. Slow stream uh, is self obvious
Obvious.
that patients feel that the stream is slow, and this is actually, it is said that in women it is mm, this is a rarely reported symptom. Until unless the stream
Okay.
is very slow, they do not report, because boys generally have the habit of passing urine right from their school age. They are made to stand together, and urinals are there, so they have those reference points from the
Okay.
beginning. Women do not, girls do not have those reference points. So whatever their flow is, that they have always thought that this is the normal. And so for them, only Euroflow, or when we say that this is not like the reference thing and this is slow, but for them to come and complain that my flow is
That's
abnormally
significant. Means
slow,
any
then
patient comes
yes,
with poor stream,
that has to be.
it's to be taken seriously and significant. It's
Yes.
significant. Oh.
Yes.
Then intermittent stream. Urine patient passes the urine, stop.
Yeah,
Again the
that is
intermittent.
another symptom. This is also self obvious. Intermittency is intermittent stream, stopping, starting, stopping, starting. So it can be like partially the urine comes in stream, and then rest half can be intermittent, like or it can be from the beginning. In intermittency also there are two type of patterns. One is like there will be some stream that is continuing, but then there is it comes fast for some time, then it doesn't touch the baseline but doesn't stop altogether, but then it slows down considerably, and then again, or it can be like it can be like that altogether stops, and then patient has to wait for a few seconds, and then it starts again. That can happen uh, mostly with I would say generally underactive bladders, this is more common to
Okay.
see that it is stopping and coming to the baseline. Then regarding
Prolapse, it can happen. Bladder outlet obstruction. The patient strains also.
yes, obviously
Continue
it can
there.
happen.
And I think
In
that patient also
prolapse can,
uses Valsalva avoiders that are patient abdominal, because when it stopped in again the patient had the reflex tendency, or might be
when
not
I say
necessary.
Valsalva voider, that is a physiological Valsalva
Okay,
voider.
straining of
Yeah, when
abdomen.
the straining happens
Hmm.
to increase the flow, that is a pathological thing. But
Okay,
Valsalva voider, as far as I
that's
think, is
normal.
a kind of a norm.
Normal. So again, we saw the hesitancy, poor stream, and the intermittent stream. Again, same continuing again with the same complaint extent. Straining during urination. Only the patient comes with straining. As you said, the intermittency is one of the causes
Yes.
underactive detrusor. So I think straining.
Yes, we were discussing straining. Straining में कई बार many times even patients will tell that I need to push, exert force in order to produce stream of urine, or she will try to increase the speed of her urination, and at times it is so much that they even pass feces along
Okay,
with
that
urination. So
because
that much can be the extent of that strain. And many times you should also be inquiring of hemorrhoids and checking for that also, because it can lead to hemorrhoids. Very rarely some hernias, umbilical
again
hernias.
we know that it's always a multidisciplinary approach. It can be multiple things by only one complaint the patient may have. So next, the spraying, splitting. The physician usually say that it's like spreads the urine when she
Yeah,
passes.
this is a rare symptom in women. Generally, if the meatus is involved, see,
Okay.
stream will be splayed or split only when there is something obstructing
Obstruction.
it.
The same
So
like a tap water when it's
yes,
something
when it starts.
obstruction. Obstruction
So
is there.
when that will happen is either meatus is stenosed,
Okay.
or it is happens very soon after reconstruction. When we reconstruct and there are
Urethroplasty
stitches
and
still
something.
there, so
Okay.
urine comes and then hits that obstruction, and then starts going in all the directions. At times, in very obese women, it can also be a symptom where this can be seen, where the labia sort of cover the orifice, and
Okay.
then after
In
the
cases of like lichen planus that
not
also.
necessarily, not
Okay.
necessarily that in very obese women, it can be
Okay,
the
just
bulk
because of
of the
that
external genitalia that
fat
can
and
sort of
can
obstruct,
obstruct
and
the.
then that can also lead to the splaying. Many a times, labia minora addition of labia
Hmm.
minora, that can also be there.
Sorry.
So I have a couple of times I have seen uh, women where they complained of poor stream and splaying of stream and post-void dribbling, urine
Hmm.
coming out later, and uh, they had adhesions in the labia minora. So the urinary orifice
Okay.
was all
Just covered so.
covered, and nobody examined that. So there was only a pinhole that was
Is
leading to
there.
everything, and then urine was going back and collecting in the vagina, and then dripping out gradually once they covered themselves.
Same continuing this in जैसे आपने बताई दिया symptoms है next terminal dribbling of urine. Patient voided, but the last act of urine is the dribbling and dribbling.
Yeah, so that can also happen, and that is many a times that can be a symptom of irritation in the trigone area, something
Okay.
irritating there. So terminal dribbling, because patient does not feel that everything has come out, and they try to sit, and then few drops come
Hmm.
again, few drops come again. So that can happen there.
Just form of cystitis or that maybe
Yes,
having it.
even symptom of stones, bladder
Okay, anything
stones.
which is hits the
Yes,
trigones, it can
yes.
have that trouble with it. Common complaint I think which falls in clinical practice need to incomplete sensation of incomplete emptying of bladder.
So
Patient voids and they're
so
having the still the sensation that it is not completely
So
voided.
this can happen also in there are two types to this. Incomplete sensation of voiding is one is I'm sitting on the toilet seat and I have passed most of the urine, but I need to sit more because I feel that there is still something left inside. So this is one, and then there is another type where one gets up and
Okay.
immediately, even before coming out of the toilet, they
The
feel that there
sensation
is
again.
yes.
Need to immediately revoid.
Yes, and many a times you will see that patients complain like this, and then if you check, there is no post-void residual urine, but just that feeling. And many a times you can also see otherwise, that patients do not complain of this, and there is a lot of residual urine inside.
Okay,
So
both the ways can be.
it can be.
So what may be the cause? Residual urine, okay, that comes as a different category. But when there is no postcoit residual, why this sensation? It's like persistent sensation of urgency, which we see in usually cases of low neurotract symptoms. They are persistent sensation.
There can be many ways in which this feeling can happen. If the urinary passage is obstructed and some urine is trapped there in the proximal urethra, then that can continue to give rise to this feeling, because the urine is there in the urethra, that reflex can be there. Many a times detrusor hasn't yet finished its function, and is trying to expel the last few drops, so that can also give rise to this feeling. So
the same extension of this only need to immediately revoid again in the same cases. Yeah.
Yes.
Need to, it's I think overlap of symptoms.
Yes,
जैसे आप
there
बता
is
रहे
no
थे.
overlap.
Post micturition leakage. Just the patient has done the urine, and when during wearing of clothes, with I think same
Yes.
extension.
During wearing me, once she gets up, and then she notices that just after she comes out, she notices that underpads are wet again, and underwear is
Yes,
wet
very
again.
true, sir.
So this is where urine gets trapped in the external genitalia or in the vagina. So again, that can be because of the bulk of the external genitalia, or some labial adhesions, or something covering there, so it goes back in the vagina. So it is a common symptom in young girls also, post-void dribble. So so what we suggest, if there have been many instances that I got to understand that this is the problem. So in such cases, we tell them that they should be holding their labia apart while passing urine, or young girls who cannot understand this, we ask them to sit backwards on the toilet seat. So the legs are far apart, wide apart, and urine can come out unobstructed, or using an Indian toilet. Squatting, that's the best. Yes, that is the best, if possible.
Urine dysuria means pain during makeup. Once is then UTI usually is there only pain here, but apart from UTI also the patient complains that everything is okay, but by urinating, patient is having pain. Might be at the urethral tip or in general.
Yes, this is also a very common symptom, and many times they say that there is pain in the urethra, and urethral pain. It is said that it is a sort of it is a very common symptom in strictures. It can also be in other
Many
forms of
other conditions are there,
but in strictures it is common to feel that pain and burning there in the urethra. But then that it is a non-specific thing, and it can be there in so many things. Bladder pain and perineal pain.
So, but
is
this is
so
also one of the body
wide.
complaints. Patient while
Yes.
urinating, this is okay. Then position dependent micturition. This is
Yes,
also
that is another very common thing that we get to hear from patients, that they are not able to pass urine when they are
in any particular
sitting.
position or
Yes,
sitting.
and then they have to
Stand
get up,
or lean forward
they have to
also.
get up, they have to lean forward, hold something on,
Yes,
and
then
be in
they
some
have
position.
to
And so, although there are hardly any studies on this, but it's a difficult symptom to understand as well. Why this is
just to
happening?
interrupt, there are two groups of in this also. One is patient usually have this means it has developed over a period of time. One is after operative, especially I've seen after VH anterior colporaphy, patient complains that initially it was now at a certain position only she runs. So it might be related to surgical or it has manifested later.
Yes, it can also be a thing of prolapse also. Pelvic organ prolapse also can give rise to this position dependent.
So, but after operation, it has been corrected, and when the catheter patient when the initially she had body good, now after
there, because no natural angles have changed now,
because of
so maybe because of this. I haven't noticed this very often.
And without operative, what might be the cause? Something anatomical or
Again, any of these symptoms, whatever we have discussed till now, the all of them are voiding symptoms, and any of them should not make you think that this may be the cause of this
specific.
obstruction, but this should get your mind thinking that there is some problem with the body, and then uh, you should be evaluating, getting at least a urine flow and post-void residual urine, and maybe getting them to fill the symptom questionnaires,
Just
to know
more
more.
details about the position dependent. So it's like a structural only defect, or it may be a functional, or
It
may
can
be
be a functional.
it can be
It
pelvic
can
floor
be
dyssynergy
functional.
also, which
Definitely,
that patient is not able to relax in the proper position.
Underactive bladder
Can be there also.
in underactive bladder they try many different positions.
Maneuvers and
Yes.
just
So
Valsalva pressing of the
Valsalva can also be there.
also. So that can be both structural and functional. Chronic urinary retention. Patient goes repeatedly. I think this
So
itself
chronic
is
urinary retention is patient goes repeatedly
for urination. Small amount is the patient gets. They have to go to repeatedly and small amount of urine is coming. That also is one of the
So chronic urinary retention is a sign. It is not a symptom.
Patient goes
Chronic urinary
repeatedly and
retention
patient
means,
gives the complaint of small amount. She has to go repeatedly, like urgency,
yes,
repeated passage,
why
but
that happens is because, say,
bladder
the
is
capacity is 400 ml, and every time she passes urine, 200 ml she is retaining. So the available capacity for her is only 150 or 200 ml. So as soon as it starts getting near to the capacity, she will feel the urge again. So many of them are having obstruction or underactive bladder. Either of these can be there, and it can manifest as increased need to pass urine. It can also manifest as persistent dribbling and overflow incontinence. So in during the daytime, she may be able to perceive the sensation, and may be able to go and visit the toilet and again empty it. But in the night, she starts leaking because it starts overflowing. So that can be a symptom. So but it is, you will come to know only when you get either you examine, it's palpable per vaginal, it is palpable, or it is seen on the ultrasound that
so I think when the patient such complaint leak at night, so like enuresis, bloodwetting. So one of the, we can say,
yes,
that this can
they
also
will present
as enuresis
enuresis,
also, nocturnal enuresis
yes,
also one of the. I think last symptom, I have finished my symptoms of voiding dysfunction. Last, I want to ask you regarding learned voiding dysfunction. Throw some light on this, sir. There are, I think, children,
so
many.
just hold on to this question. All these questions that you have asked patients, it is very difficult for patients to come up with all these symptoms in questionnaires only, or if you go very specific.
We ask the leading question.
Yes, but it is not that uh, only when patient complains of these voiding symptoms you should be evaluating for voiding. There are storage symptoms like frequency, urgency, urge incontinence, nocturia.
Stress.
Any of these symptoms, can also be a presenting symptom of the voiding dysfunction. So many times when we presume that anybody coming to us with frequency and urge incontinence, urgency and urge incontinence, it is an overactive bladder, idiopathic if the culture is normal. But I don't agree with this. It can be chronic retention also with the patient. It can be chronic retention. It can be just in, as in men. What happens in men is the age when prostate starts causing some obstructive symptoms. So bladder gets irritated, and when bladder gets irritated, it can present 33 to 40% of men with BPH can have uh, just mm, just the storage symptoms. Okay. So any man who is coming to me with this, I will first evaluate him for voiding problem. And if I see that his flow is abnormal, I will give him alpha blockers, and that will solve his storage as well. But when it comes to women, I don't know why are we so blind about it. That I have seen many people starting anticholinergics, bladder relaxants, then increasing that it goes to as refractory, adding the second, then refractory. So once I even saw a patient referred to me for Botox injection, and then I got a Euroflow and found that there is voiding problem, and she had a dysfunctional voiding, and physiotherapy decreased.
I think functional dysphony is also one of the.
So and it is said that bladder is an unreliable witness. So bladder is an unreliable witness
Also
means this is I think it was, I do not know, who wrote this first.
But we
But
have, when I
yes,
had learned at
I
AIMS
read
New
it
Delhi,
in
many of the teacher always used to say this bladder is an unreliable witness.
yeah.
This I have heard a
You
lot.
should one should read, if anybody is interested in this, one should read Professor Chappell's. I read it in
Okay.
Professor Chappell's one of the reviews, that bladder is an unreliable
Read
witness, but it
selected.
has been said much earlier, I think in 70s. So it's an unreliable witness because it just tells that there is some problem with me. It will not tell you that if I am having voiding problem. So if you see in the book, then
Hmm.
avoiding symptoms and avoiding problems,
These
they
are
can be
overlap.
excused. Yes,
Overlap.
yes. So it can be that, like that.
So we'd like to continue much more, but I think symptoms are finished, and because of
And you were asking me
learned voiding
of learned
dysfunction.
voiding dysfunction. So
That's just a
learned,
whole huge, a different topic, and I think
yes, it is different, but of all the voiding dysfunctions, the most common is
functional.
functional voiding disturbances are either underactive bladder or bladder outlet obstruction. Bladder outlet obstruction can be
In
structural.
female, it's
Structural.
usually prolapse. Most common in female, if we go bladder outlet obstruction.
Not necessarily.
Okay.
Not necessarily. Prolapse is said to be
Uh,
earlier, and in the books it is so common. But to me,
Practice
in my practice, there are many women
with other
who
causes.
without prolapse
I
can
think
have
pelvic floor dysfunction, that how to
pelvic floor
relax.
dysfunctions. Then there are bladder neck
Neck
obstructions,
obstruction, Fowler
and
syndrome. That is, I
then
think,
there are
rare.
strictures which were thought to be
Uh,
so rare, but they are
Common, not that
actually
rare.
not that rare.
Not that.
Not
This
that
I
rare.
have seen.
So in these, if we exclude even strictures, and learned voiding dysfunctions are more a spectrum of dysfunctional voiders, where
Okay,
patients
yes.
do not release their sphincters
Sphincters.
to pass urine. When they have to
Mm.
pass urine, they don't release their sphincter. So why this happens is because, if I have to give a glimpse in of why this happens, when they are supposed to relax, they
They
are not.
contract.
So they are in a habit of keeping it contract.
Contract.
Girls who learn to hold urine for long
Long
hours and
hours.
avoid going to toilets, many times women who just
Yeah, this is the problem.
start
Females usually, because of the route accessibility,
yes,
or by voluntarily they avoid to go to washrooms, and
yes,
just
and many times I have seen that women who have started uh, their professional life, now they have mm, a working place where men are also using the same toilet, so they are reluctant, and they, or if they are in a sort of common office where every time if they get up and they are seen every time going to the toilet, they don't want that, and then they hold on to that urine for long hours, and then they forget
to relax, and
to
it gets
relax.
habituated. Means,
So
I think they, even female, don't know that they are doing this problem,
yes,
and
and
they will
many times
develop
it
it.
can also be after some acute UTI or
Okay,
some of
yes.
that episodes that mind, then even after treatment of UTI
Mind get,
from yes, it
reflexly it's there in the mind.
reflexly it holds the
So
urine
that
and
only the
forgets the
female does
relaxation.
not know that
So
they
that
are
they have to be retaught
how to void.
voiding, and retaught how to relax their pelvic floor. That I'm sure you see all this every now and then, and you are asking me as if and you
So
are listening.
please, so please.
Uh,
The very expert, I said, no, I'm like really sitting as a student and sir is teaching. So just to summarize, sir has different very beautifully and each symptom. What I think we should give you a take home message. What I think is points of all the voiding dysfunction when the patient complains. Even if with the storage disorder, you need to take the detailed history of the voiding function also. More than the history, because patient is not able to correlate, you need to evaluate the voiding dysfunction. And I would request sir to give some take home messages when the patient of voiding dysfunction, or any how to do focus on voiding dysfunction.
see, there is only one way. Any woman who is coming with any lower tract symptoms, you have to assess each symptom in detail and get a uroflowmetry and a post-void respiration. That I think is the minimum before you treat anything. Even urge incontinence
Incontinence or
or stress,
SUI.
even stress incontinence.
Continence,
Because many times it can be mixed incontinence, many times it can be related with avoiding dysfunction. I think that is the least that we should do. And then there are so many symptoms, you can go in detail. If need be, you can refer to the expert, then they can be
No,
really
obviously.
evaluated.
Yes.
Yeah.
And just to add on, sir, even I think normal uroflowmetry does not rule out that patient does not have any body dysfunction. If she complains, patient complaint need to be attention,
Yes.
because abdominal straining also lead to a false raised
Yes.
Qmax.
Just the
Bell-shaped
Qmax,
curve,
just the Qmax doesn't rule it
and
out.
even the bell-shaped curve
Many a times, just the
even
bell-shaped
curve
curve.
also
Yes.
does not relieve
Yes.
that. So first is most important. Urogynecology is all about a good history, and a good history,
Good history.
and the evaluation. So
Then there are.
okay.
It is not just the voiding symptoms. There is something more. It is the entire pelvis. All these organs crosstalk.
Okay.
So
You need
if there
to
are
focus on
any constipation, if there is any sexual pain, so everything, because of the pelvic floor muscles, everything comes together. So you should not be only confining yourself
to
to
the voiding
to
problem.
just the voiding. This is another take.
No, so just
Yeah.
because today's topic is voiding, so I just want to, yes, but definitely multidisciplinary approach. Even if patient just complain about urinary, then you need to evaluate the sexual and the bowel complaint. And here to add on, just as in my previous video, I said constipation is basically a root problem of all urogynecological problem. Constipation may also lead to a recurrent UTI. I hope sir will agree with this.
Yeah.
Many patients have
Yeah.
constipation; they themselves don't realize that they are constipated.
Yes.
So it was a very nice session. With thank you again, sir, for giving the valuable time and literally teaching us for this. And we hope more to learn from you in the near future.
Thank you.
Thank you. Thank
so
you,
much.
everyone. Thank you. So this was Dr. Nikhil Khattar from New Delhi, and we are very grateful and thankful for the sir for teaching us, literally teaching us on this. But it's very huge topic. So we have just tried to very comprehensive and overgive you an idea what is voiding dysfunction. If you want to literally go to detail and learn literally about each point, how to go and evaluate another, I can definitely refer to the female bladder obstruction, female bladder outlet obstruction by Sir Dr. Rishi Nair sir, Dr. Nikhil Khattar sir, and Dr. Arvind Pandey. So I request everybody so who are interested or who want to learn, do refer this book and read. And any questions you can ask, please put on the comments. Dr. Nikhil Khattar sir will answer to you all your questions. Thank you. Thank you so much for being with us.